A man walks into his annual physical feeling completely fine. No pain, no symptoms, nothing wrong that he can feel. 40 minutes later, a scan finds something small on his kidney, and from that moment, his life becomes a different life. 18 months of follow-up imaging, a biopsy, sleepless nights before every appointment, conversations with his kids that start with "just in case." In the end, the thing they found would never have hurt him. It was removed anyway, because once something is found, almost nobody has the nerve to leave it alone. This isn't a rare story, it's a pattern. And it's exactly why, after 62, there are 5 checkups I would think twice about before agreeing to. Not because testing is dangerous by nature, because at this stage of life, some of these tests quietly stop protecting you and start creating problems that didn't exist before you walked into the clinic. Start with the full-body cancer screening panel, the kind sold directly to consumers as total peace of mind whole-body MRI or CT imaging, bundled with broad tumor marker blood work. On paper, it sounds like the ultimate safety net. In practice, it's built to catch what pathologists call the iceberg of indolent disease. By your 60s, your body has quietly accumulated small abnormalities over decades, tiny nodules, slow-growing cell clusters that your immune system has been managing without incident the entire time. Modern imaging is extraordinarily good at finding these things. It is far worse at telling you which ones actually matter. That gap is precisely why the U.S. Preventive Services Task Force has never endorsed routine whole-body scanning for people without symptoms or specific risk factors. The evidence doesn't show it saves lives in the general population. What it does show, consistently, is more biopsies, more unnecessary procedures, more weeks spent waiting on results that were never going to change your outcome either way. None of this means skip screening. Colonoscopies, mammograms, and lung CT screening for long-term smokers all carry strong evidence behind them at the right ages. The real line isn't between screening and no screening. It's between a targeted test built around a clear purpose and a wide net cast just to see what floats to the surface. The second one catches almost everyone off guard, a cardiac stress test, when you have no symptoms at all. If you're feeling chest pain, breathlessness, or unusual fatigue right now, stop watching and get evaluated today. That part isn't up for debate.
But this is about the otherwise healthy 63-year-old who feels completely fine and just wants a stress test to check on the heart, purely as a precaution. Here's the problem. In people without symptoms, these tests carry a meaningful false positive rate, flagging a blockage that isn't actually clinically significant. And a false positive rarely just ends with a shrug. It typically triggers a coronary angiogram, an invasive procedure that threads a catheter through an artery to inject contrast dye. Generally safe? Yes. Risk-free? No. Bleeding, vessel damage, contrast reactions, all real possibilities for a problem that may never have needed finding in the first place. What actually protects your heart at this age isn't a test you take once a year to feel proactive. It's your blood pressure, your cholesterol, your blood sugar, 3 numbers, checked consistently, acted on, honestly, simple, inexpensive, backed by decades of outcome data that most people never bother to look at twice.
Third, and this one touches almost everyone eventually, bone density scanning, done far more often than it needs to be. The DEXA scan itself is genuinely valuable. Don't skip it entirely. The trouble starts when someone with only mildly low bone density, a condition called osteopenia, gets rescanned every year or two and is pushed straight onto long-term medication before anything else is tried. Bisphosphonates, the most common class of bone drugs, do help people with real osteoporosis and high fracture risk. They also carry rare but serious risks with extended use, a condition where jawbone tissue breaks down, and, almost cruelly, an increased risk of a specific unusual thigh bone fracture in some long-term users. A bone-protecting drug that can, in rare cases, cause the very kind of fracture it was meant to prevent. For mild bone loss with no other major risk factors, current guidance actually supports spacing repeat scans to every 10 to 15 years, not every one or two. And the single most powerful bone protective habit available to you doesn't come in a prescription bottle. It's resistance training. Lifting weights, resistance bands, body weight strength work a few times a week has been shown again and again to preserve, and in some cases improve, bone density in older adults alongside adequate calcium, vitamin D, and cutting back on smoking and alcohol. Get the scan when it's genuinely indicated. Just don't let one borderline number rush you into a decade of medication before you've tried the thing the evidence actually favors first. The fourth one deserves real care because it touches genuine fear. Many of you have watched a parent or a spouse go through cognitive decline, and wanting to know your own risk early is completely understandable. But here is the honest picture right now. Genetic testing for Alzheimer's risk genes, or brain scans checking for amyloid in people with no cognitive symptoms, currently offer very limited ability to change what actually happens to you. Treatments that modestly slow progression do exist for people already showing early symptoms, and that research is genuinely moving forward. But learning you carry a risk gene years before any symptom shows up rarely leads to an intervention that changes your path. What it reliably produces instead is years of anxiety, altered life planning, and quiet strain on your entire family built on a probability, not a diagnosis. Forgetting a name occasionally, misplacing your keys, that's normal aging, not an early warning sign. If you or your family notice a real persistent change in memory or function, see a doctor. That's a different situation entirely, and it deserves attention. But testing out of curiosity alone, with no symptoms present, is a decision worth sitting with before you make it, because the psychological cost is real and immediate, while for most people right now, the medical benefit simply isn't. And finally, the one urologists have been quietly walking back for years without most patients ever hearing about it. Routine PSA testing for prostate cancer well into your 70s and beyond. Prostate cancer becomes extraordinarily common with age. Autopsy studies have found prostate cancer cells present in the majority of men in their 80s who died of something else entirely: heart disease, another illness, simply old age, having never known the cancer was there at all. That's the core problem with PSA screening this late in life. It's very good at finding slow-growing cancers that were never going to cause harm. And once something is found, the instinct for doctor and patient alike is almost always to treat it. Treatment carries real lasting consequences: incontinence, sexual dysfunction, bowel issues, persistent fatigue. For a man in his late 70s or 80s with a slow-growing, low-risk cancer, those side effects can outweigh any benefit the treatment was ever going to provide. This is exactly why major guideline bodies, the American Urological Association, the U.S. Preventive Services Task Force, have moved toward discouraging routine PSA screening in older men, particularly those with limited life expectancy. Men in their 50s and 60s with specific risk factors, family history, or certain ancestries linked to higher risk may still have a strong case for screening. That's worth a direct conversation with your doctor. But an automatic PSA test at 78, simply because it's always been on the checklist, deserves a second thought before you roll up your sleeve for it. Underneath all 5 of these sits one idea worth carrying into every checkup you'll ever have again. Not every test that can be done should be done, and more testing was never automatically the same as better healthcare. Medicine, for all the good it does, is still partly an industry, and somewhere inside that industry, more scans mean more revenue, whether or not they help you personally. That doesn't make every test a scam. It means the question worth asking every single time is simple. If this test finds something, what will actually change? What would we do differently? And are the risks of that next step smaller than the risk of simply leaving it alone? When nobody in the room can answer that clearly, that's your signal to pause before you agree to anything. None of this is an argument against your doctor or against screening itself. Blood pressure checks, blood sugar and A1C testing, cholesterol panels, thyroid checks, vision and hearing exams, dental care, appropriate colon cancer screening, all of it remains genuinely valuable after 60, because all of it leads somewhere useful. The difference was never between doing tests and refusing tests. It's between testing that leads to something you can act on and testing that mainly leads to fear. The years after 62 were never going to be measured by how many scans came back clean. They're measured by how well you actually live inside them, how you move, what you eat, who you sit across the table from, and how clearly you understand the body you've been living in for 6 decades. That's the kind of health no scanner will ever print out for you. And it's the only kind worth protecting first.